Hello and welcome to Amanda's Wellbeing Podcast, a podcast where we discuss all things relating to your well-being, including interviews with experts in the fields of nutrition, physical and mental health, and my 5-minute food facts series. I am Amanda Hayes, your host, a lawyer turned nutritionist with a passion for well-being. Before I introduce today's guests, I will mention that although I will often be speaking with experts, any information or advice provided in Amanda's Wellbeing Podcast is not intended to be used to treat, cure, or prevent injuries or medical conditions, and is not a substitute for advice from your own health professional. Today I am here with accredited exercise physiologist Brendan Mouatt. Brendan has several roles, including he's part of the Body and Mind Research Group at the University of South Australia. He is an educator and director at the Knowledge Exchange, and he's a director at the Biomechanics practice. Brendan will explain to us what all those different roles entail, but the main focus of our topic today is pain. I will be speaking to Brendan about the causes of pain and how pain can be treated in a clinical setting. So today I am here with Brendan Mouatt. Hi, Brendan.
Hi, Amanda. How are you doing?
Good, thank you. Thank you for coming on my podcast today. Brendan, you're an accredited exercise physiologist. So what led you to study exercise physiology and where did your interest come from?
Good question. I kind of fell into it a little bit, I think. I always loved exercise and movement and got a lot of enjoyment and benefit physically and mentally from exercise. And, having sickness in my family and that sort of stuff, I think I saw from a young age sort of physiotherapy working with, people like my mother and whatnot with chronic conditions. And I thought that would be quite a rewarding sort of area. So I was a personal trainer for many years and then went down an exercise science pathway and, I enjoyed that, but it didn't kind of really set you up for in particular. And then, so I had these options of physiotherapy or exercise physiology and I ended up going down a pathway of exercise physiology. And I could say that, during my master's, I still wasn't exactly sure where I would end up, but I've sort of developed a passion over time, I guess, from really just engaging in that and learning more and more about people and movement and how all these things fit together.
Fantastic. And I will speak to you about all the different roles you have. But first of all, where did you study and how long did it take?
Yeah, it's ongoing. It's never really stopped since I started. So I did my an undergrad in physical education and exercise science at Victoria University in Melbourne. I did my master's of exercise physiology at Deakin University in Melbourne, which I think you're also a grad of Deakin as well.
I did my master's in human nutrition there. Yeah.
Yeah, awesome. And so that was great. And then I went into clinical practice for a number of years and really sort of engaged in a lot of continuing education courses at that point. And but then I've sort of gone back and I'm just finishing now my master's in research, and I'm about to start my PhD. So
fantastic.
That's all really exciting. So it's kind of going on for far longer than I ever expected, but I've grown to absolutely love learning and learning more about what it is we do and how we can do it better.
Yeah, that's great. Can you explain to me and to the listeners, in case they don't know, what is the actual difference between the role of an exercise physiologist and a physiotherapist? Do you get that a lot, by the way?
I do, and my response is probably very different to a lot of other people's response. And, I think it comes down a little bit to who I'm working with, and generally in a clinical context, I'm usually working with people in pain, musculoskeletal sort of injuries and whatnot as well. So sort of in that context, I think when someone's coming in to see us, whether it's a physiotherapist, an exercise physiologist, a chiropractor, an osteopath, if we are actually being, in line with the evidence and practicing, guideline care, but then being person-centered, it really shouldn't differ too much from each other in the sense that, that person should be dictating what's going on. It should be very specific to them. And, if it is remarkably different from one person to the next, I sort of question myself to, well, how person-centered are we being then if it is that different?
Yeah.
So I think there's a lot of crossover, and I think everyone's got their own individual skills, but the difference between one exercise physiologist and another exercise physiologist could be greater than the difference between me and one other physiotherapist.
That's very interesting.
If that makes sense. So
yeah, it makes perfect sense. So you mentioned earlier musculoskeletal pain, and that is one of your passions, I believe, treating people with spine and musculoskeletal, that's a difficult word, pain, and to help manage persistent pain. And on the Knowledge Exchange website, which is one of the things that you do, and we will talk about that in a minute, you say that no matter how many different techniques you applied, and I believe you've trained in several different techniques, some people responded rapidly and others with similar presentations did not, and you wanted to know why. And you say this led you to a dark and deep search to make sense of these varying presentations. So I was thinking, I understand how that could be a deep search, but what was dark about it?
It really was, and it still is probably to some extent now. I think the way we're trained, the way we're taught, and the whole way our society talks about pain and injury is really ingrained. There's a lot of tradition, a lot of belief. That's quite dogmatic. We've just taken it on board and we've run with it. And when I was sort of training and doing these other continuing education courses, I'd be going in, there'd be this, really inspirational kind of guru who would teach you this technique or these strategies for dealing with people in pain. And you learn these very clear-cut ways of how to fix people. And for me, I think when I started to kind of engage a little bit more in the research behind these sorts of things, I started to notice that they didn't really kind of hold true, or they weren't any better than any other technique or strategy or whatever when we look across the population. Right. So I was like, why does that make sense? I'm seeing some people improve rapidly and other people's not. So why is that occurring? And I think it led me to really having to critically appraise or look at myself and my own beliefs around how I practice and how I work with people in pain. And in doing so, I think it started to really challenge who I was as a person. I think I realized that I'd really attached my beliefs around how I work with people and me as an exercise physiologist to my identity itself. And so whenever that's challenged and your identity is challenged by, contradictory information, I think we have this kind of visceral response, this kind of backfire effect, this, sympathetic nervous system, fight or flight, kind of pushing back, and you kind of go, no, I don't want to hear this. And I think a point where I was ready to sort of listen and hear and try and reconcile the way I viewed the world to kind of make sense for my patients, the people I was seeing, to better help those individuals. And I think for me, that was very challenging. I think that is very challenging for a lot of clinicians who've been taught a certain way. And then there's, contemporary new understandings around pain and rehabilitation that really kind of challenge that. And I think that can be really, really difficult. And so I think for me, it was just very grounding and humbling to go, hey, we don't have all the answers here, and I need to be open to updating my belief system and really sort of figuring out, how do I make sense of what I see in the clinic and what we see in the research, and contextualize it for that individual who's sitting there in front of me seeking help.
Yeah, that's really interesting, because I think I could say the same in the sphere of nutrition. You really have to keep an open mind, because the science is evolving all the time, and you can't really afford to attach yourself to certain paradigms, because things change. So it sounds like the scientific research in the area of pain is similar in that as we learn more, as you say, it can contradict some of the things that we thought were, solid scientific evidence, and it's not in the end.
Yeah.
So, Brendan, you have several roles these days. You are part of the Body and Mind Research Group at the University of South Australia. You are an educator and director at the Knowledge Exchange, and I believe you're a director at the Biomechanics practice as well. So can you talk us through each of these roles and what you do there?
Yeah, sure. So, as I said before, I've gone back to study research. So that's what I'm doing at the University of South Australia. So I get to work with some incredible people here and learn from people. You walk into the room and you just feel like the dumbest person at any time. And I think that's one of the greatest sort of situations you could ever hope for. And I really kind of enjoy that sort of environment. And so I've got a clinical practice with a couple of great business partners as well. And so that's based in Footscray in Melbourne. And so that's a multidisciplinary group of practitioners. So we've got exercise physiologists, podiatrists, osteopaths, personal trainers, and whatnot, all under one roof in a nice big gym space and some treatment rooms and whatnot. So that's exciting. And then, the knowledge exchange is this our own continuing education business. So that's all based around trying to translate evidence-based practice, things that we're seeing happen in the research, into implementation. So how getting clinicians basically upskilled and being able to use this information in a meaningful way to really help people in the community.
Oh, right. So your clients are then other clinical practitioners, are they, not lay people so much?
They are in the knowledge exchange and in that continuing education. Yeah, so that is more for sort of allied health professionals, right. GPs as well. And then on the side, obviously, I'm still seeing clients and working with them in a pain and rehab context.
And you said that the biomechanics practice is based in Footscray. So normally, would you be travelling back and forth between Melbourne and Adelaide?
A little bit. COVID's been a nice break from the travel in that sense. But obviously it poses its own challenges at the moment, owning a business in a place that's so locked down. A bit of travel, but I still, in terms of practice, I practice in Adelaide myself. But otherwise, otherwise a fair bit of wireless also wired contact with Zoom and whatnot, with team meetings and organisation from that side.
Yeah, no, it's really interesting how businesses have had to adapt, often very quickly. What's happening in Melbourne with your biomechanics practice there? Has it gone Zoom based or something like that?
Yeah, so it's all telehealth at the moment, and so we had to sort of adapt very, very quickly, like many other businesses, to sort of accommodate for that. But we've got this great team who I think very comfortable with approaching healthcare from from a Zoom context and being able to really kind of validate, explore, and start experimenting and finding opportunities to help people move forward again and gain that control. So I think quite often we think someone has to be there in person and doing things to us. But I think this has provided a really nice opportunity to show that actually, they're great adjuncts to be able to, have that hands-on therapy and whatnot. However, we can do a lot, and actually the really powerful and most important things are probably what we get people sort of in control of, and we can do that, I think, through, psychologically informed communication strategies and really exploring their ideas and setting up strategies for them to start figuring out ways forward as well, and supporting them in that sense.
Yeah, look, you're not the first person who's said that in terms of being able to treat through telehealth rather than having to be physically present together. I guess the silver lining in that situation is that it does increase your reach. I mean, you can see a client who's based in, another country, another city, through the telehealth model. So that's, I guess, if we're looking for some COVID silver linings, there would be one.
Yeah, absolutely. I think it's probably, and I'm not certain, but probably improve the quality of care for people living in rural communities in terms of their access to different practitioners and care, and and force us to really upskill as clinicians to be better at these types of interventions and strategies moving forward. So it works and it's helpful, and people I think are getting a lot out of it, which is really cool.
Good to hear. So then if we move on to talking about pain, So I understand, because I've done a little bit of background reading here, that the causes of pain are very complex. And there's a lot of scientific research in this area, which you've alluded to, and you're obviously also contributing to yourself. So I'd like to ask, if it's not impossible, can you explain in lay terms what is pain?
It is complex. And it's a great question. Look, to be honest, it's one of those things. Like we've got, some formal definitions of it, and it's been debated in our, scientific community a lot. And only recently was it sort of updated again, and that's still being challenged and spoke about. But I think at the end of the day, like sort of when we're talking lay terms, it's whatever someone says it is. I experience pain, and I know it's unpleasant. It's sensory. I feel it somewhere in my body. It's emotional, like there's a real discomfort to it.
Yeah.
And it can make you feel different ways and then act in different ways as well. And that's a subjective experience to me, and there's no way for me to understand what it is like for you, Amanda, to experience your pain at all. And so when you come into my clinic, I think it's really important that we kind of acknowledge that whatever someone perceives pain to be for them it's real pain all the time. And so one of the things was kind of, really sort of learn in more of a contemporary understanding of pain is that pain's more of an experience than it is, indicative of specifically tissue damage. It's definitely associated when we break down a tissue or we have an injury, but that's not necessary nor sufficient alone to result in someone to experience pain. So what that tells us is that pain is then influenced by lots of other factors, such as everything that's happened in your past before, your experiences, your beliefs, your knowledge of the world, and then all of the other factors that are happening around you at that point in time. So what you hear, what you can see, the environment, the people you're with can all influence your pain. And I think that makes it really complex because, you'll have the people who go, my pain's always worse when it's dark outside and it's cloudy and whatnot, which is like, how would that affect your tissue? That's such a weird thing. But it starts to help us make sense that actually, pain is influenced by all of these other contextual factors as well, and not just the state of our bodily tissues. And in fact, we can have, our tissues heal and, or there's a lot of people out there that's probably, they have pain right now and they've had imaging done and their scans have come back and there's nothing there. And so then they're worried that, are they faking it, or is this just all in my head? And it's absolutely not. It's, the pain is absolutely real, but it is telling us that it doesn't have to be something wrong in a tissue. And it just kind of now allows us to open up to the idea that in terms of treating that, we can start looking at all of these different things that are very individual to a person's experience, to start finding those opportunities and ways forward.
It sounds a bit like you have to be a detective. You're not just looking at the physical presentation, you're looking at the patient's mental state as well and all the contributing factors. Would you say that people have different pain thresholds? Like two people can have a similar injury and experience it very differently?
Oh, yeah, absolutely. And we've got some really cool experiments that have looked at this. Laura Mosley, who's a very charismatic pain researcher in our research group. A few people may have heard of him before, and he talks about one particular study where if you squeeze your fingertip as hard as you can, you can elicit an experience of pain. If a friend does it to you, it's always more painful. All right. And so there's like this element where it's just like this change in one thing. The pressure can be exactly the same, but the control now is, or that context of control is slightly different. And now your pain experience is completely different. And then we see this in the real world as well. You can see people with really debilitating, back pain and have very, very minimal damage or issues going on with their back. And then these, people who have huge damage, and at the end of the day they're completely asymptomatic, no experience of pain whatsoever, and it just tells us we've got to look a little bit more deeply and listen to people and listen to all of the other things that are going on in their lived experience of the
Yeah,
world.
that must be fascinating. You say there's various ways to classify pain, and obviously it relates to your mental state. You talk about musculoskeletal pain. So can you just explain to us what that is, what type of pain that is?
Yeah, look, I think at the end of the day, the kind of pain is pain. Like I sort of said before, and when we sort of talk about musculoskeletal pain, we're often talking about like it feels very, in one particular area of your body, and potentially associated with actual damage or some kind of condition within that joint or that tissue of some sort. But at the end of the day, I mean, pain is pain, and you can have musculoskeletal pain. And once again, like I sort of said before, is not necessarily a huge amount of damage to that tissue, but that pain still feels very much in your elbow, your knee, or wherever it might be. But other factors might be influencing why you feel it in that area.
So if you are facing a client with pain and obviously you're trying to help them and treat them, do you need to know the cause of the pain? Is that part of the diagnosis or not?
It's always important, and it's one of those things that's important in sort of hearing the story of someone as well. If there's a mechanism of injury, like they've done something, or they've been in an accident, or they were turning quickly playing netball or whatever. We've got a mechanism of injury that suggests that there's probably some tissue damage here. All right, and that's still doesn't tell us that's like the sole, the only factor we've got to look at here. But it tells us, all right, there is a real underlying driver to the sensitivity around that area of the body. And so, yes, we've got to now take into account, natural healing times, or whether or not other surgical interventions or whatever else needs to be put on the table. And then, the appropriate loading of that tissue over time using exercises or movements or whatever it might be. Are sort of taken into consideration, but it's always still considering the other aspects of that person's experience. Because I think someone who's going, this means I'm never going to walk again, or I'm never going to play netball again. I'm really stressed because I've got to go home and look after the kids now. And how am I ever going to do this? How am I going to go to work and put food on the table? We know all of those factors have a huge bearing on whether or not someone's actually going to make a full recovery, or that they might go through all the stages of tissue healing and all that structure come good, but they've still got this sensitized nervous system that's still protecting them because there are all of these other stresses. And so I think we've got to really take into account that, we're dealing with human beings here. We're not just dealing with a knee. We're not just dealing with a back or whatever it might be at any point. And so it's just saying, hey, let's listen. Let's look at all of these things, and nothing's off the table in a part of a good rehabilitation program. It's like, all right, how do we better support people? How do we make sure that they've got the tools and strategies they need to fully recover and re-engage in all the things in their life that they love doing again?
So it's coming through absolutely loud and clear that you can't separate the experience of pain from a mental state. And I think there's obviously reasons for that if you're looking at the way the body works, and this is going to be very much oversimplified, I'm sure, but sensory receptors send message via nerve fibers to our spinal cord and our brain. The sensation of pain is processed and then perceived. So in one of your blogs where you review recent research into pain, you talk about pain and fear. You say that the fear of pain can lead to the avoidance of a specific activity that results in pain, leading to this cycle of avoidance and a potential increase in the disability. Clearly, treating the pain is more than the physical side. It's also the patient's state of mind. And I'm just wondering, do you ever need to work with psychologists and psychiatrists in addition to your own treatment?
Yeah, absolutely. I think that's important for some people, that are, dealing with some psychopathology, some other things where they might want some support with that as well. And what you just said, Amanda, I think is really, really important is there is no circumstance, while we are alive where our body and our mind can be separated. Yeah. Like they're always interplaying. We just cannot do that. And so to be just treating one of, that and ignoring, the experience or just ignoring the tissue and only treating that is kind of like a futile attempt. They're all kind of always engaging and at interplay with each other. And so I think that's important. So yeah, absolutely. Like, making sure people have, those other types of support. And I think another...
If they need it.
Yeah, exactly. If they need it and feel themselves that is important as well. And a lot of the time it's not. I think clinicians are getting better in terms of like physiotherapists, exercise physiologists, podiatrists and so on, are getting better and engaging more in just the psychological components of what they're doing. And so they're not turning into, complete psychologists by any means, but they're becoming more informed of how they can kind of navigate someone's, complex story and ensure that they are getting the support they need, and also being able to, be just another caring human being that can support, just another fellow human being in a complex world that we live in. I think just to kind of go back just for 1 second as well, in terms of like, what pain is and what you talked about is, we're getting these signals being sent from tissues to our spinal cord and then they come up to our brain. And it's important that we kind of actually understand now that, they're not pain signals. They're kind of more, if we can conceptualize them more as like danger messages.
Yes.
And it's the brain's job then to kind of take that information and go, all right, with everything I know about the world so far and everything that's happening around me, is this danger information actually, really threatening to right now? And if it deems to be like, there is a lot of danger here for me, it's going to be a useful experience or output to have, then what we tend to see is that we're going to be more likely to have a protective response like pain or stiff a body part or, even an immune response and so swelling and so on as well. So pain doesn't sort of happen kind of in the tissue so much. It's the brain's job to do that, but we will feel it in and represented in that joint or that part of our body.
But then how do you explain referred pain? So you... and again, this will be a very lay description, but say you physically hurt some part of your body, but you experience the pain in a different part.
Yeah, absolutely. I think you're alluding very well to the complexity of it as well. And so, we've got representations within our brain for all of these different body parts, and they can have close representations and they can be associated in different ways. And so they can have sort of pain in one area. And I think one of the sort of examples you came up is, when we're having, a heart attack, we're going to have a jaw pain or a pain going down our arm or something like that. Whereas where the tissue is going wrong is elsewhere. And so, that's an area I'm probably not that well versed in, but, we've got similar, pathways and sharing of sensory information through different regions of our brain, as well as our body as well. And so
it just illustrates the point of how complex it is, really, doesn't it, I think? If you're in your clinic and you have a patient who is experiencing fear about their pain, what are some of the ways you can approach trying to help them?
Yeah, absolutely. So I didn't really talk to the fear component before, got sidetracked. And so I think sort of to go back to that is, if someone comes in and for example, they've got this belief or they've been told that they've got bone on bone knee osteoarthritis and they've been told that, they shouldn't ever do any exercises or they need to be really careful for the rest of their life. Obviously, it would be very normal and it makes sense. It's almost common sense to then go, I've got a fear about them loading it, about moving, about doing things with this knee. And so we're going to probably behave in a certain way associated with that fear. And that's probably going to be avoiding going to a gym or avoiding running or avoiding anything that hurts whatsoever. And when we start to avoid things that hurt, obviously it takes less and less for it to then hurt. And so what we often see is we kind of pace ourselves into more and more disability over time until we just can't function in our day-to-day lives anymore. And so when we kind of look at that from a clinical perspective, it kind of like listening to the person's story, and we're kind of gathering and trying to identify what are the things that they're worried about, and why, what kind of underpins that, what are the beliefs, what have they been told before, and then determining, is this an adaptive strategy? Is it actually helpful? Is this something that, they need to be doing? Or is it potentially an unhelpful belief or unhelpful fear that is actually kind of getting in the way? And so I think what our job is to do is kind of identify, it's like, okay, is it safe to load this knee or this person's body in whatever way? And to what extent is it appropriate? And then how do we start to challenge that more and more over time? Now, that could be really, worrying for someone individually, and that's where sort of developing, really good trust with your practitioner or your client, depending on obviously what side of the conversation you're on, it becomes really, really important. And having that trust, then go, all right, I know you're worried. I know you're fearful of this movement. Would you be open to kind of exploring that? Well, I'm not going to do anything that's going to put you in harm's way. It might be a little uncomfortable, a little bit, unpleasurable. Would you be open to exploring it though? And that can be the first step, is coming up with like little behavioural experiments and little ways to start challenging that fear.
Breaking it down bit by bit.
Yeah, exactly. So sometimes it's just kind of gradually exposing someone over time and habituating them to that experience and going, oh, look, it isn't as bad as what, we first thought it was going to be like, allowing them to start to re-engage more and more and more and have their nervous system calm down and normalize. And then sometimes it's going, well, actually, it doesn't look like we've got an issue with the tissue itself. It's actually really, really safe to move right now. But that pain you're feeling right now may be driven more by all of these behavioural strategies, these protective responses like bracing the core and squeezing the glutes and trying to keep the back straight. And all of those things often can create so much tension that it becomes this experience of pain. And so challenging those in big ways can be really helpful and are often really common things that change, that result in people recovering really rapidly in some cases.
And I totally agree, because I've had personal experience. I run a lot, and I have a sore lower back, and sometimes I think the fear of hurting my back caused all my muscles to sort of tighten as a protective mechanism. And my physio, who I really trust, and he's fabulous, he said to me, he explained it all to me and said, you're not going to hurt yourself if you keep running. And once I knew that, and I knew that what I was doing wasn't causing any further damage, it changed. Brendan, if you have what would be a challenging patient for you, in that they've experienced chronic pain for decades, for example, before they end up in front of you, is it possible to undo all that pain or that fear of pain and perception of pain over time?
Yeah. Look, I truly believe it is. When we look at pain, it is a biological process. And one thing we know about biology, it's forever changing. It's always changing, and it's adapting to our environment and all of our needs as a human. And so that means it's going to be adapting to our very last breath, as a man named David Butler has famously said. And so I think that kind of should give us a lot of hope that, pain can change, or how you engage in life can change, and how you experience your pain can change. Yeah, look, I mean, some people just have these incredible stories, and 20 years of back and abdominal pain, and daily use of opioids ever since the diagnosis, and surgeries after surgeries, and countless clinicians. I mean, it ends up being often just very complex stories of, trying to figure out where do we start here? Because it's not as simple as just, what are they worried about? Let's kind of challenge that. It's going, no, how do we get this person in control of other parts of their life as well, and just moving more and doing all these things? And how do they then respond when they do have a bit of a flare up, when their pain does get worse or whatever? It just becomes a little bit more involved and whatnot. But still just as much hope for those people as anyone else. And I think that's probably a really important thing to kind of take away from that is, if you've been experiencing pain for decades, we can get used to it and be like, this is my lot in life. But at the same time, I truly believe it can still completely change. We just, not to give up hope and keep engaging in the things that we enjoy doing.
Well, that is actually wonderful news to hear, and I'm sure very, very many people will be happy to hear that. I'd like to now talk a bit about people who sit a lot. So office workers often spend a large proportion of their day sitting at a desk. And I did read on the internet, I'm not sure how accurate this statement is, but it said that Australians sit for an average of 10 hours every day at their desk. And whether that number is accurate, I'm not sure. But the point it makes is that many of us sit a lot. And I have heard sitting referred to as the new smoking in the popular press. So what I'd like you to share with us, Brendan, is some reasons why sitting all day can result in chronic pain. What are some of the causes of pain, and what are some of the most common presentations that you might see?
I wouldn't almost go as far to say sitting is the cause of pain, and we probably don't have a huge amount of data to say that it does, which is really interesting because you're right, there is these popular campaigns that smoking is the new, or sitting is the new smoking rather, and I think that's just a non-simile really.
Well, that's interesting.
And I think that's almost cruel in a lot of ways when we talk about pain and threat, and how if we perceive more threat to our body, then we're more likely to experience a protective response like pain or stiffness or something along those lines. That we have these people who are forced to sit at a desk and do their job so that they can provide for their family, do their things, and they don't necessarily have a huge amount of options to leave. And then across from their desk is this poster on the wall that says sitting is the new smoking. And you think, but why? And where has that come from?
Yeah.
And so, look, I absolutely think that, less than half of the Australian population meet physical activity recommendations. And I think it's more of a flipping it on its head a little bit here. And it's not to say that, sitting's great for you by any means, but we can sit, we can adapt to that, and that's absolutely fine. And it's healthy to do so. Mm-hmm. As long as we are still finding opportunities to move, to use our body, to engage in physical activity. And that doesn't have to necessarily be structured exercise, but, going for, a lunchtime walk or having walking meetings or finding any opportunity to kind of move or use your body in a way that kind of stresses it to some extent, I think is probably going to be one of the most important things we could do to start to offset the sedentary lifestyle. So it's more just not doing anything that's probably more the problem rather than sitting itself.
I see. Yeah. So you're saying really if you are in a job that requires you to be at your desk, to find opportunities to move as much as you can.
Yeah, move as much as you can, get out there and talk to people, and I think that's the other thing is we're correlating it to just the body thing again. Yes. And, if you are sitting at your desk for 10 hours a day and all you're doing is emailing other people, then, where's the other social interaction? We're social beings. Exactly right. So, going, all right, who would I like to spend some time with this afternoon after work? And often we feel tired and burned out. The last thing we want to do is more, do any movement or, hang out with friends. But I think, trying to find those opportunities and say, no, this is actually really important. I enjoy these things, and making time for that are probably going to be the better lifestyle choices that you can. If you don't have to sit for 10 hours a day and you're doing it and you're like, oh, then don't. Yeah. I think that's kind of like a clear thing. But if you have to, I'd say don't beat yourself up about it, but find those opportunities and kind of engage in that way. And I think that's probably going to be a better way and aligns with the research better than saying that, sitting is the new smoking.
Right.
I just don't think is factually correct.
Oh, that's good to hear too. So, Brendan, if someone does need to sit for, several hours during the day, do you have some tips then on some good ways or optimal ways to sit? If you do have to do it, are there techniques you could possibly think about, like do you sit straight, do you brace your core, things like that?
Yeah, well, I mean, they're the really common things that we hear in all of the campaigns out there in social media land and everything else, that you should be sitting upright, you should be bracing your core, you should be, in these kind of rigid positions where you've got that 90-degree knee bend and all of those kinds of things. And now what's really interesting about that, because that's exactly what I was taught and the way that I was trained, that when you kind of dig a little bit deeper to where those ideas come from, they're not actually built on sound evidence whatsoever, which is really fascinating, right? And so what we're starting to see now emerge in terms of the relationships is going, if you do try and sit really up straight and brace your core, you're probably going to fatigue faster and you're going to be more uncomfortable. And then if you have that belief that you should be doing that and you start to feel a little bit of pain, discomfort, you'll probably just brace more and sit more upright.
I think I'm not doing it properly.
I know, yeah, it becomes quite circular and you become exhausted by the end of the day and you're going, well, I've got so much tension through my neck and everything else. And so what we're kind of seeing now is going, all right, so one is we've got to look at, the workplace efficiency, like making sure you're, set up where you can move, within your space and do your work efficiently, effectively, and that's not too stressful. But also, what's comfortable for you? I think this is like the biggest rule, is just go, what's comfortable for you? Like my anatomy and your anatomy, Amanda, is completely different. All right. Yeah. To expect us to both have the exact same postures and whatnot the whole time is ridiculous. But like I just said before, is more movement is better as well. So where you can kind of take one posture and then move to another posture and go, oh, this is comfortable now, and now this is starting to get a bit uncomfortable and sensitive, move to another one, or get up, have a bit of a stretch, move around, and then come back and find what's the next comfortable posture you've got. And so it's like, it's not saying posture doesn't matter, but it's just reconceptualizing what we mean by posture. It's just there's no bad postures. You slouch if you feel like slouching. At the end of the day, you're sitting on the couch. Why would you have a couch if you're sitting up straight on it? Sell it and buy a really uncomfortable rigid chair. Right? It's just such an interesting thing that we've kind of built up a whole industry around sitting upright.
It's like drinking bottled water. People have stopped drinking tap water. It's sort of this marketing that it's, great and clean and all that stuff. And actually it's contributing so much pollution into this world, and it's not really necessary. Well, certainly not in a country like Australia. But what about, Brendan, the standing desk situation? Because that's also very popular. Do you think that's beneficial?
I think it's great for, some people are, really sensitized now sitting and maybe because they're just not moving enough or whatever it might be that's kind of led to them, becoming more sensitive and potentially having these protective responses. And so I think standing desks can be great to just give people another option that they can move. And once again, like we talked about, just finding another posture to sort of sit in, it just gives you another posture that you can stand in. Just another option. But, if all you're doing is using a standing desk, it's no better than just sitting in the same position for, 10 hours a day either. So I think it's a nice thing where you can kind of start to move around, you can move up and down, it just gives you variation. And that's what we're starting to see now in sort of all the research around posture and movement, is that, for a long time we've been trying to get everyone moving and having postures that adhere to this perfect norm. However, no one's got that perfect norm, and most people without pain are far from the norm. And so we don't need to be adhering to these. And in fact, it's quite the opposite. It's just the more variation we have in our movements, the more likely we are to, be, successful movers and less likely to become sensitized from being in one position too long, because we've got lots of options now to sit in and allow different tissues to, put some work in or take some of that force.
So some of the things you're saying is comfortable position, variation in your posture, and move at, every opportunity you can, walking meetings, etc.
Yeah, absolutely. So probably upset a few people that are in there trying to give workplace ergonomic assessments right now. But I mean, when we really are critical of the research and what we know of big population studies, is it doesn't seem to turn the dial added by doing that, it may even create more of a problem, and it costs a hell of a lot as well.
It
So
does, yeah. Oh, very, very interesting. I'm really glad I asked you those questions because it certainly has changed my perception a bit. I've kind of believed in the whole, oh my gosh, I can't sit because it's like I'm smoking a packet of Marlboro Reds here. So, not that I've ever done that, mind you.
yeah, sure.
It's almost time to wrap up, but I just wanted to ask you quickly one question about exercise because you are an exercise physiologist. One thing I'm always curious about, and I really don't know if there's an answer to this, but there's always been a bit of a sense of no pain, no gain, particularly in sporting arenas. So if you're running and you experience pain, are there some general guidelines as to whether you should push through it or whether you should stop? Is that something you can talk to?
Yeah, and I think that becomes like it's a very broad question though as well.
Yes, it is.
But no, but you're absolutely right. I think it's a good question nonetheless. I think we can kind of like run through a few different questions in our head to, is this something we've experienced before? What do we think's going on?
Mm-hmm.
And, do we think it's safe? And why do we want to continue as well? Like, are we doing it because like we're going to let the team down and I've never had this pain before and it's starting to build up and it's getting worse? Then I think, that kind of answers your question. If they're the reasons why you're doing it, then you've got to weigh up the pros and cons of that. And, that's up to a person. If you kind of, you've only done, 1 or 2 kilometer runs for the last, year, and then all of a sudden you're doing a half marathon and you're kind of 20, getting towards the end and your knees on fire and it's just been building up. It's going, well, we can probably surmise that the amount of load that you've just put through your body is far beyond what you trained for. And so your capacity probably wasn't there. And you're probably going to be dealing with a bit of a tissue-based injury. And so backing off is probably going to be a good way to do it. But if it's kind of like, I feel a little bit of a niggle, then maybe just try something a little bit different. You can kind of experiment, like what happens if I just try to run a little bit differently or try to relax through my core or something like that, to see if you can gain a little bit of control over it. And, a lot of the time, I'll start to have a bit of a run and a bit of a niggle in my ankle for a second. And then I'll just go, all right, hang on a second. Let's just play around with this a little bit and, let my body kind of become accustomed to what it's doing right now, and it all kind of fades away. And I think it's one of those things of just kind of getting to know your body by doing that activity regularly, but kind of gradually building up and adding either the resistance or the difficulty or the length of it over a period of time. And I think then it becomes a little bit more clear going, no, this is abnormal and I'm actually a little bit worried about that. Then, hey, just back off, give it a bit of a break, keep moving within your tolerances, and then start building back up afterwards, I think.
Listen to your body, ask yourself some searching questions, and probably let go of your ego, perhaps, is something as well.
Yeah, unless you just can't let go of your ego. And I know that there's some of us out there that are cannot do that, and that's fine too, but there's sometimes repercussions for that. But we can all make our own decisions, I guess, at the end of the day.
Yeah, at the end of the day, you don't have your exercise physiologist on your shoulder when you're running a race, do you? So to make your own call. Brendan, to wrap up, who inspires you?
Oh, there's lots of people. I think I mentioned a bit earlier today that, some of the people I get to spend time with here at the Body and Mind Research Group. One of my supervisors, Tasha Stanton, and she does incredible perceptual research and whatnot, and a really good communicator. She's fantastic. Obviously, Lorimer Mosley, very clever guy, great speaker as well. And then we've got this great team in our clinic in Melbourne, and they're just, I learned so much from them and the way that they engage in the challenges of our current healthcare climate, with COVID and everything else that's going on. I've just learned so much from them and really inspired by the way that they go about things. Like, I'm very, very lucky that, we've got such a great group like that. So, there's just so many good people out there and willing to help and change and challenge the norms. And I think for me that they're the people who are making the real changes in in healthcare.
It sounds like you've surrounded yourself with a really wonderful group of people, so that's great. Finally, a question that I like to ask all of my guests: if you could recommend 2 things that people could do to improve their well-being, what would they be? They can be anything.
Do make time for things you love doing. Don't and I think that's probably like one of the big things in rehab. Often they're the first things to go.
Yeah.
That we stop doing those things or spending less time with the people that we just enjoy hanging out with. So do the things that make you feel good, and with the people who you love doing it with, that makes you just feel like, the world's incredible. I think that's such a underutilized strategy to recovery. And for a second one is just move more. Enjoy moving. Using your body. There's no right or wrong way to move, as what we talked about before, and that might be really challenging some people, because that's not what we talk about in our industry. Where it's always about the right and wrong way to do something and lift and all of those sorts of things. And what we're starting to see now is like, no, that's not the case. Your body is unique. It's incredible. It has resilience, and it has the ability to do lots of incredible things in different ways. So explore movement and find different ways to do things. And, even if you are an exerciser, try to find different ways to do the common exercises that you do, and explore that, and kind of give yourself the freedom to use all of the different available options you've got. And I think if we're kind of doing those things, then we build a more resilient, robust capacity within ourselves.
So that is excellent advice, and really you're saying have a go, try lots of different things, use your body.
Yeah, enjoy it rather than kind of feel bad about it, or all those sorts of things. That I think there's a lot of shaming in our community about postures and movement and all that. It makes it harder to engage in exercise, and we've got to get rid of it, because it's not founded on anything other than often healthcare professionals' egos and training. And if it's not founded in the science, then what's it really doing? It's just someone's idea that's kind of extrapolated across, and now becoming a barrier to people engaging and enjoying their bodies and movement.
Oh, that is wonderful advice. So, Brendan, thank you so much. It's been a real pleasure chatting to you today, and thank you for being so generous with your time and your knowledge.
You're welcome, Amanda. It's been really fun having a chat with you.
And that was exercise physiologist and researcher Brendan Mouatt challenging some of our accepted beliefs about pain. If you want to check out Brendan's research, I'll put a link to his ResearchGate profile in the show notes, and I'll also put links to his clinical practice, the Biomechanics, and to the Knowledge Exchange, where he is a director and educator. Thank you for listening today. I hope you found today's interview interesting or inspiring. If you did, please share the podcast and tell your friends about it. And if you could take a minute to leave a rating on Apple Podcasts, it will help people find my podcast. If you would like to subscribe to Amanda's Wellbeing Podcast, you can subscribe on all good podcast providers like Apple Podcasts, Spotify, Stitcher, Spreaker, iHeartRadio, and Google Podcasts. You can also subscribe on YouTube. Please follow me on Instagram and Facebook at Amanda's Wellbeing Podcast, and check out my website at www.amandaswellbeingpodcast.com, where you can contact me via the contacts page. And please feel free to suggest topics you'd like to learn more about and people you'd like to hear interviewed, and I will do my best to deliver that to you. Producing the podcast is a labour of love. It has become my full-time job, to which I dedicate a lot of time, money, and effort. If you enjoy my podcast and would like to support it, I would be so grateful. You can make contributions via my Patreon page, which is a bit of a work in progress, I must admit, or via PayPal from the support page on my website. I'll put a link to that in the show notes, so please do check it out. Another way you can support my podcast is by purchasing a book from the book reviews page on my website. If you click on the Amazon link there, at no extra cost to you, I will receive a small commission when you buy a book, for which I would be very grateful. Thank you for tuning in. Eat well, move well, think well.